Assalamu alaikum everyone. I am Dr. Syed Ahsan Ali, working as a senior medical officer and National Institute of Liver and GI Diseases and the Dow University of Health Sciences. Uh, topic The topic of the article today to be discussed here is rebleeding and mortality risk are increased by ACLF but reduced by early tips. So before starting, I want to thank Dr. Zaigham Abbas and all the faculty of PSSLD for providing this platform for the juniors like me to discuss these articles. So this is the article that is accepted in the Journal of Hepatology to be published in the year 2020. The article has yet not been published, but it will be published in the year 2020. So before proceeding towards the study design and analysis, I would like to discuss few basic things here regarding variceal bleed, ACLF, and early tips. So acute variceal bleeding, 70% of all upper GI bleeds and cirrhotics has been identified as a common cause of death in patients with cirrhosis, with a 6-week mortality around 20%. And 20% of these variceal bleed patients encounter treatment failure after initial endoscopic and medical treatment, and that is associated with a high short-term risk of further liver decompensation and death. So I would like to explain a few definitions here. Uh, first of all, that is time zero. This is the time of admission to a medical care facility, and clinical significant bleeding is defined as transfusion requirement of 2 units of blood or more within 24 hours of time zero, together with a systolic blood pressure below 100 millimeter of mercury and a postural systolic drop of more than 20 millimeter of mercury and a pulse rate of more than 100 beats per minute at time zero. And the time duration of acute event is taken as 120 hours from the time zero, uh, that is uh, around 5 days. And treatment failure is defined as fresh hematemesis or more than 100 ml of fresh blood and the NG aspirate after 2 hours after the start of a specific drug or endoscopic treatment, or the development of hypovolemic shock or drop in hemoglobin of more than 3 grams per deciliter within a 24-hour period. And rebleeding is defined as significant bleeding that occurs after 120 hours from the time zero. Any significant bleed that occurs within 120 hours is defined as treatment failure, while any significant bleed that occurs after 120 hours is considered as variceal rebleeding. And factors associated with poor outcomes with variceal bleed are higher child Q score, higher the MELD score, renal failure, bacterial infection, active bleeding at endoscopy, HCC, and HVPG more than 20 millimeter of mercury. So these are the few studies that have shown the following as the risk factors for the poor outcomes for variceal bleed. And the Bavino 6 suggests the use of early tips in child PUB patients with active bleeding and endoscopy despite on being vasoactive drugs. So those patients who are child PUB and after despite of receiving vasoactive drugs in the ER or in the early resuscitation, and when the patient goes for endoscopy and while endoscopist insert the endoscope and there is still active bleeding, so these are considered the candidates for early tips. And same is for child PUC patients who are presented with variceal bleed and their score is less than 14 points. So these two group of patients are considered as the candidates for early tips, and these are this is suggested by Bavino 6 guideline. And several studies have shown that early tips within 24 to 72 hours after admission leads to significant improvement in relevant clinical outcomes. So these are the few studies that have shown the impact of early tips in child PUB patients who are bleeding actively at while doing endoscopy despite receiving vasoactive drugs, and child PUC patient with a score of less than 14. And the benefit of tips probably rely on the prevention of further deterioration after failure of initial treatment, avoiding subsequent increase in rebleeding, organ failure, and death. So variceal bleed is a well-known trigger for the development of ACLF. However, the role of ACLF and the outcome of patients with variceal bleed has not yet been investigated. These are the few studies which have highlighted that variceal bleed itself is a trigger for the development of ACLF. And what is ACLF? It's a syndrome characterized by acute decompensation of chronic liver disease associated with organ failures and high short-term mortality. There is a heterogeneity in the definitions of ACLF. According to Abbas, acute hepatic insult manifesting as jaundice and coagulopathy complicated within 4 weeks by clinical ascites or encephalopathy in a patient with previously diagnosed or undiagnosed chronic liver disease and is associated with a high 28-day mortality. This definition was first coined by Abbas in 2009. Later, it was updated in 2014. And according to ACLF, ACLF always occur in the setting of acute decompensation, and the extrahepatic failure is a major differential feature of the syndrome with high short-term mortality. This is a table representing the extrahepatic organ systems that are taken in account in CLIF SOFA score for the ACLF. So these organs are liver, kidney, brain, coagulation, circulation, and the lungs. And this the different grades of severity of ACLF depending upon the organs involved. So according to ACLF, if there is no organ failure, there is no ACLF, and if there is single renal organ failure, then ACLF is classified as grade 1A, and if there are two organ failures, then ACLF 2, and if there are three or more organ failures, it is defined as ACLF grade 3, and the severity of the ACLF increases with the number of organs involved. So now coming back to the study, this multi-center international observational study addresses three clinical relevant issues. Number one, the prevalence of ACLF-8 admission in patients with acute variceal bleed. Number two, influence of that ACLF-8 admission on variceal bleed outcomes, that is rebleeding and mortality. And then the impact of early tips on mortality of ACLF patients with variceal bleed. So now coming back to the study design and patients taken in this study. This study has been conducted using the database of a multi-center international prospective observational study by the Bavino Corporation to evaluate variceal bleed in cirrhotic patients in 34 centers between October 2011 and May 2015. So basically, this study has used the database of another large study that was conducted by the Bavino Corporation in 34 centers, European centers, between October 2011 and May 2015. And all patients were managed according to guidelines of Bavino 5 consensus and the AACD guidelines. Patients at high risk of variceal bleeding, i.e., those the child to grade C patients or grade B patients with active bleeding at endoscopy despite the use of vasoactive drugs, were considered to receive early tips based on individual center policy. So the PTIPS placement was based on individual center policy, and patients were regularly followed for 1 year until death, liver transplantation, or the end date of follow-up, whichever came first. Medical history, clinical biochemistry, and endoscopy findings, treatments, and outcomes were recorded during hospitalization. And the primary outcome of this study was all-cause mortality or liver transplantation at day 42 and 1 year, and the secondary outcome was rebleeding. While in this secondary ancillary study that we are to discuss today, the influence of ACLF at admission in variceal bleeding evolution and the role of early tips in the outcomes of ACLF patients was analyzed. And ACLF at admission was retrospectively defined and graded according to ACLF definition, and liver, kidney, and coagulation failure was assessed by bilirubin, creatinine, and INR levels, while brain failure was evaluated by West Haven scores of hepatic encephalopathy. Circulatory failure was considered when vasopressor therapy was needed to maintain blood pressure. A total of 233 patients treated with vasoactive drugs to maintain blood pressure was defined as circulatory failure. And respiratory failure was diagnosed when mechanical ventilation was required for reasons other than the airway protection. So, no patient recorded with renal replacement therapy, at least at enrollment, but renal dysfunction and failure was defined by the creatinine value as defined by EASL CLIF definition. And a total of 686 patients were admitted in the ICU, and the length of ICU stay was recorded with a median of 5 days. The ethics committees of all participating hospitals approved the study protocol, and all participants included in the study had provided written informed consent. Now, the data management and statistical analysis. Unified RedCap electronic data capture system was used to record and manage data. And RedCap is a basically RedCap is a browser-based electronic data capture software and workflow methodology for designing clinical and translational research databases. A steering committee was formed to monitor data consistency and correctness, and stroke guidelines were followed for reporting observational studies. And stroke guidelines are basically a checklist of 22 items that were created to aid authors in presenting their work, and it is not used as a validation tool for conducting the study. Rather, it was created just to aid the authors to present their study work. Continuous variables were described as median and interquartile range. Categorical variables as frequency and percentage. Main Whitney test or Fisher's exact test were used to compare group of patients where appropriate. So the main Whitney test is a non-parametric test of null hypothesis, and while the Fisher's exact test, as you all know, is statistical significance test. Cumulative incidence function curve with Gray's test were used for survival analysis, and Gray's test is used to evaluate hypothesis of cause-specific cumulative incidence function between two groups. Univariate and multivariate competitive risk Cox regression model were used to identify independent predictors of 42-day and 1-year rebleeding or mortality. Potential risk factors that were significant in the univariate competitive risk analysis were included in the multivariate analysis to analyze the subdistribution hazard ratio. Cox regression analysis is a method for investigating the effect of several variables upon the time a specified event takes to happen. And subdistribution hazard ratio describes the direction of the effect of the covariate on the risk of the outcome, but not the magnitude of this effect. To confirm the robustness of results, sensitivity analysis was performed comparing patients with ACLF receiving early tips with ACLF patients not receiving early tips by propensity score matching. And propensity score actually allows one to design and analyze an observational study so that it mimics some of the characteristics of randomized controlled trial. A two-tailed p-value of less than 0.05 was considered significant, and all statistical analysis were performed using the SES software or SPSS. And the two-tailed test is a method in which the critical area of distribution is two-sided and tests whether a sample is greater than or less than a certain range of values. So the results of this study. So the baseline characteristics and the prevalence of ACLF at admission in patients with variceal bleed. A total of 2138 patients were enrolled in this study. Patients were predominantly male and the median age of 58 years. Majority had alcoholic etiology. Of all included patients, 380 had ACLF at baseline with different grades of severity. So this is a flow chart representing the baseline characteristics of the patients enrolled. Of uh, around 2138 patients were enrolled in the study with the variceal bleed, and of them 380 had ACLF on admission. Of these 2138 patients, 671 were eligible for early tips according to individual center policy. And of these 61 patients, 671 patients, 169 had ACLF at baseline and 502 didn't have ACLF at baseline. Of these 169 ACLF patients that came with variceal bleed, 22 received early tips while 147 received the standard care of treatment, depending on the individual center policy. Of these 22 patients receiving early tips, we can see there's a the mortality 42-day mortality is around 13%, while uh, by the patient who had ACLF at baseline and didn't receive early tips, their mortality rate was around 51%. So there is a marked difference in the mortality of these two groups, representing the impact of early tips in patients with ACLF with variceal bleed. ACLF patients were similar in age and gender when compared to non-ACLF patients, but showed a higher frequency of alcoholic etiology. And as expected, patients with ACLF more frequently presented with ascites, SBP, encephalopathy, and HRS, and higher the male and child P score at baseline. However, patients with ACLF had a significantly lower rate of previous bleeding, but a similar rate of primary prophylaxis compared to non-ACLF patients. This is a bit busy slide, but I have highlighted the important things here. Coming to the basic etiology, in ACLF group, 56% had the alcohol as an etiology of their underlying chronic liver disease, while in non-ACLF group, 45% had the alcohol as an etiology of their underlying chronic liver disease. And there was less number of patients with previous history of bleeding in the ACLF group compared to non-ACLF group, which have more percentage of the around 33% of the patient who had previous history of variceal bleed. And coming to bacterial infection, around 34% of the ACLF group had bacterial infection at the time of admission, compared to non-ACLF group, which had only 13% of the patient had bacterial infection on admission. And hemoglobin values was also there was a marked difference in the hemoglobin values of the two groups. In the ACLF group, the mean HB was 7.8 gram per deciliter, while in the non-ACLF group, the mean HB was 8.7 gram per deciliter. So was the creatinine value. It was higher in the ACLF group compared to non-ACLF group, and the INR was considerably much higher in the ACLF group as compared to non-ACLF group. So was the male score on admission. Uh, the male score on admission for the ACLF group was around 21, while it was around 10.3 in non-ACLF group with very severe. So ACLF is independent risk factor of 42-day and 1 year rebleeding and mortality in patients with acute variceal bleed. So patients with ACLF showed a higher rate of rebleeding when compared to patients without ACLF. 42-day rebleeding rate was 19% in patients with ACLF compared to only 10% in patients who didn't have ACLF on admission. And the risk of this rebleeding increased in line with ACLF grade. So this is the graphical representation of the impact of ACLF on 6 weeks and 1 year rebleeding rate. So one can see there's a marked difference in these two patient groups who have ACLF as compared to who didn't have ACLF on admission in rebleeding. If one see here at the time zero, from time 0 to 6 weeks follow-up period, around 240 patients of the ACLF group had rebleed out of 380 patients. While if we see the non-ACLF group, so in non-ACLF group, only 500 out of around 750 patients rebleed. So there is a marked difference in the rebleeding rate of the patients who have ACLF compared to those who didn't have ACLF at admission. So representing that ACLF itself is an independent risk factor for rebleed. So other risk factors along with ACLF were bacterial infection, total and thrombosis at admission were independently associated with 42-day and 1 year rebleeding, and hemoglobin appeared as a protective factor for the risk of rebleeding at day 42. So this is the graphical representation of the risk factors that are associated with 42-day rebleeding rate in all patients. So one can see ACLF, bacterial infection, portal and thrombosis, they all are increasing the rebleeding rate in patients at 42 day, while hemoglobin has come up with as an protective factor for the rebleeding at 42 day and at 1 year rebleeding. As expected, patients with ACLF were more prone to die than patients without ACLF. At 42 day, the mortality for the ACLF group was 47% versus only 10% in the non-ACLF group who have presented with the variceal bleed. And at 1 year, ACLF patient had mortality of 55% versus 23% with the non-ACLF group. And mortality increased in line with the severity of ACLF. The more the organs are involved, the more the severity of ACLF. And these effects of ACLF on survival remain as independent predictors after adjusting for confounders. So this is the graphical representation. Uh, The impact of ACLF on the mortality. One can see there's a huge difference at 6 weeks and 1 year mortality between the two groups of ACLF group and non ACLF group, representing the direct impact of ACLF on the mortality with variceal bleed. Other independent risk factors that were associated with 42-day and 1 year mortality were age, child Q score, HCC, and BUN at baseline. So these are the risk factors that are independently associated with 42-day and 1 year mortality in variceal bleed patients. So higher the child P score, infection at admission, ACLF, these all are the risk factors that are associated with the mortality at 42-day and 1 year at 1 year period. So now the most important part of this article, the impact of early tips on rebleeding rate and mortality of ACLF and non-ACLF patients with acute variceal bleed. A total of 66 patients underwent early tips, of whom 22 had ACLF. There were more patients with ACLF grade 3 who did not receive tips, and this was dependent on the individual center policy. And ACL patients receiving early tips placement had a lower creatinine and glucose at baseline compared to ACL patients without early tips. There were no significant differences in age, gender, child Q score, and other baseline characteristics. Early tips placement was independently associated with a lower 42-day rebleeding rate in patients with ACLF. And treatment with early tips in these patients reduced the risk of rebleeding due to ACLF. So this is a graphical representation of the impact of early tips in patients who had ACLF on admission along with variceal bleed. So if we see at 6 week follow up from time zero, the patients who had ACLF and received early tips, of these 22 patients, only 7 had rebled by the end of 6 weeks, while in patients who had ACLF at admission with variceal bleed but didn't receive early tips, rather were managed according to standard care of treatment. Of these 109 patients, around only 45 were rebleeding free. Around 60 patients rebled in 6 weeks follow-up period. So there's a marked difference in the rebleeding rate of these two groups receiving early tips and those not receiving early tips. And regarding mortality, and in cases where the analysis was restricted to ICL patients, patients treated with early tips presented a significant lower 42-day and 1 year mortality compared to ICL patients receiving standard of care. So the mortality was also reduced. 42-day mortality in the early tips patient who had ACLF along with variceal bleed at admission, their mortality was only 13% compared to those patients who had ACLF with variceal bleed at admission but didn't receive early tips, rather were managed according to standard care of treatment. Their mortality was around 51%. And at the end of 1 year, early tips group had a mortality of 22% versus the patient who did not receive early tips, their mortality was 56.5. So there is a marked difference between these two groups who received early tips versus the patient who didn't receive the early tips. So treatment with early tips reduced 42-day and 1 year mortality after adjustment for confounders, and similar results were found after adjustment for Cliff ACLF score instead of child Q score in the Cox regression model for 42-day and 1 year mortality. So this is the graphical representation of the impact of early tips on the mortality at 6 weeks and at the end of 1 year. So one can see that of the 22 patients at the time zero, of these 22 patients at the end of 6 weeks, 16 were alive, but 6 had died uh, due to reblade. While if we see the patients that did not receive the early tips, so of these 147 patients, almost 100 had died at the end of 6 weeks. So there's a marked difference in the mortality between these two groups. Same is the for at the end of 12 months. There's a marked difference in the mortality of the two groups receiving early tips and those patients who did not receive early tips and received rather the standard care of treatment. If we limited our analysis to patients with bilirubin more than 5 milligram per deciliter, early tips significantly increase survival and rate in patients with ACLF, regardless of hyperbilirubinemia. So there is a marked difference in the mortality rates of ACLF patients with variceal bleed that received early tips compared to the patient who had ACLF with variceal bleed who did not receive early tips. So at the time zero, seven of there were such seven there were seven such patients with bilirubin more than 5 milligram of per deciliter and had ACLF with variceal bleed. So of these seven patients, only five were alive at the end of 6 weeks. But if we see the patient group that didn't receive the early tips, these were 70 such patients who had bilirubin of more than 5 milligram, had ACLF with variceal bleed at admission. Of these 70 patients, only 19 were alive at the end of 6 weeks. So there is a major difference in the mortality due to marked impact of early tips in patients with ACLF with variceal bleed at admission. In the absence of ACLF, patients treated with early tips also had a lower mortality, but without reaching statistical significance. So early tips reduce the mortality even in patients who didn't have ACLF at admission, but had variceal bleed and had child PB score with active bleeding at the endoscopy, or child PC with score less than 14. I mean, these patients had uh, were benefited with the relatives but without reaching a statistical significance. But it is here important to remark that the study was not designed to analyze this fact and it is underpowered for this analysis. So, coming to the discussion regarding this study, this is the first study to describe the prevalence of ACLF and its relationship with rebleeding and mortality in patients with variceal bleed. ACLF is an independent risk factor for rebleeding and mortality in variceal bleed patients. Moreover, patients with ACLF and variceal bleed may benefit from a early TIPS placement. The study found that a substantial percentage of variceal bleed patients present with ACLF. One of 5 to 6 variceal bleed patients presented with or developed ACLF during the hospital course. And ACLF almost doubled the risk of rebleeding, easy identification criteria for patients with rebleeding risk. Interestingly, ACLF predicted this independent of the presence of portal vein thrombosis, which is a well-known risk factor for rebleeding. These are the few studies that have shown the impact of portal vein thrombosis on the variceal bleed. And results showed that ACLF is a major independent risk factor for rebleeding and mortality, and that it may justify or even require more aggressive treatment. So it is the first time ACLF has come up as an independent risk factor for rebleeding. We all already know that ACLF has impact on mortality, but this is the first study that is describing a relationship between rebleeding and ACLF, and it has found that early tips has been introduced to treat patients with high risk of treatment failure. Previous studies have also shown that early tips can improve the prognosis of patients with variceal bleed. These are the few studies that are published in different journals of hepatology that have shown the role of early tips in patients with variceal bleed. While this study suggests that early tips could improve the survival of patients with ACLF remarkably, therefore this therapeutic tool should be considered in the management of ACLF patients with variceal bleed. The consequence of this hypothesis would be to transfer the affected patients to hospitals with access to tips, thereby potentially reducing their mortality by 75%. These data are nicely supported by a recent study which showed that higher the male score, the bigger the survival benefit after early tips. So this is a study that has shown that higher the male score, higher the survival benefit of the early tips placement in patients with variceal bleed. So coming to the study limitations, while the data collection process of this study is prospective, multi-center, and large-scale, it lacked the on-site monitoring visit of a randomized controlled trial. Moreover, ACLF was diagnosed retrospectively in the patient since the study had been planned before publication of the ACLF criteria. and the precise information on vasoactive drugs used were retrieved from the electronic case report forms. And those patients treated with vasoactive drugs to maintain the blood pressure were defined as circulatory failure. So we didn't don't know exact the number of exact their blood pressure values. Rather, all the patients who were received the vasoactive drugs, they were defined as circulatory failure. And data regarding ACLF development after variceal bleeding were not collected. So it is not therefore clear whether bleeding precipitated the ACLF or it was an event in the ACLF already in the patient already suffering from the ACLF. And the limitation is the limited number of ACLF patients treated with B-tips. There is only 22 patients with ACLF they were treated with early tips, but this is the largest and first study in investigating the association between the variceal bleed patient with ACLF and early tips. And they've not mentioned the frequency of complication in patients receiving early tips like encephalopathy and heart failure, as we all know, are the major complication of the tip. So these are the few drawbacks of the study limitations that need to be addressed in future studies before application the conclusion. So the conclusion is this large multi-center international study confirms that ACLF is frequent in variceal bleed patients, that ACLF is an independent predictor of rebleeding and mortality, and that early tips could improve survival in patients with ACLF and variceal bleed. So this is all from my side. Now it's now the time for the questions and the discussions.
Okay. Dr. Zaigham and Dr. Saleh have questions, so I'm putting up Dr. Zaigham first.
Nice
Please.
presentation,
Thank you,
Hassan.
sir.
And you have done very well. So this study shows that variceal bleeding leads to ACLF, and ACLF in turn leads to variceal bleeding. Is it true?
Yes, sir, this study shows that ACLF itself is a precipitating factor for the varicose bleed is the itself a precipitating factor for ACLF, and ACLF
And
in turn can lead to increased rate of rebleeding in these patients.
yeah. So my question is that patients who received tips, what was the level of ACLF in those patients? I mean, they were having one organ failure, two organ failure, or three organ failure.
Sir,
So that is, to me, is also important. Was there any consideration of that also that they made while doing analysis?
Sir, actually, when they did the analysis, they took the whole ACLF group, ACLF patient as a group who received the early tips. But one thing, what they noticed is the more of the patient with ACLF grade 3 were not given the early tips. Is early tips placement was according to individual center policy. So the more the ACLF grade was, the lesser they were referred for early tips. So it's a valid point that can we refer patients with more organ failure for early tips. So these are the few things that needs to be addressed in future studies, I think.
Okay. Is that all from Dr. Zaigham? Okay. Dr. Saleh, I am unmuting you. Please comment, and if you have any question, please go ahead.
Assalamu alaikum,
Right,
Hassan.
Sam,
Very
sir.
nice presentation.
Thank you, sir.
I have a few comments and some discussion, I would say more.
Sure,
One
sir.
is that when we say tips, it has been of multiple types. While it's the study use a preemptive tips rather than an early tips or a salvage tips
So yes, sir,
or an
preemptive
elective
tips.
tips. An elective tips is usually for type 2 HRS or refractory sites, while a salvage tips is to salvage an uncontrolled ongoing bleeding for
Exactly, sir.
after failed endoscopic treatment. While an early tips means that if the patient rebleeds and then you do a tips rather than going for endoscopy, you have not wrong on that one. While a preemptive tips is the one will be a prophylactic approach, another is preemptive. Prophylactic means that you have something which predisposes you, and you do in advance a procedure or an intervention, which is a prophylactic. while a preemptive means that you have that event, and now you see some indication that this patient, like the child score is high, or he is still having an active bleeding while you do an endoscopy after vasoactive drugs have been started. And despite that, you do an intervention, you go for a TIPS. So what I'm getting is a preemptive TIPS means that even if you band ligate these varices, but there were high stigmata for a rebleed, they went for a TIPS rather than a salvage TIPS in case of a rebleeding occurring and then going for a TIPS. So that was one clarification. That's what I'm
Yes, sir.
getting from it. The other thing is that whenever one has an ACLF, um, there are only few exceptions. Like one is an alcohol, and the second one would be probably hepatitis B or
Reactivation.
reactivations or related decompensation, which may at times will improve with interventions or abstinence. While the other in other conditions, once you have an ACLF, you have days to weeks to decide the timing of a liver transplantation. So one should never forget that as well, because the mortality is still very high, even if you do tips or whatever, or you don't do a tips. If your creatinine goes beyond 1 point, up to you have got only renal failure, and then ACLF 1A or 1B, because they have not divided it, as Dr. Zaigham mentioned out, into a different classes of ACLF.
Severity.
But if you've got a severity of the ACLF, then if it is a 1B or beyond, I would say whatever you do, the mortality will be still high, and even reaching up to 80 or more percentages. And probably one would like to stabilize the patient and proceed with uh, the liver transplantation.
Liver transplantation.
So like that. The other issue would be, like you observe, that referring these patients for an preemptive tips rather than using a word of early tips.
Okay,
A
sir.
preemptive, these patients will be quite sick. They are bleeding
Exactly.
and they will be quite sick. If they've got an ACLF of 1 or so, a 1A or a maximum 1B, then you may transport them. But beyond that, it will be very difficult. So it will be nice to manage them, though if you have the facilities of an early of an ability of tips at your center, you would consider them. But it should not be a blanket statement that all ACLF patients presenting with an variceal bleeding are going for a liver, for preemptive tips. One. Second, they also mentioned the portal vein thrombosis and HCC. Now,
Hmm.
portal vein thrombosis
Itself is a
was,
contraindication.
no, it's not. It's a relative one.
Relative.
It's a
Relative.
relative one in a way, because these days they can do tips with PVR, which they call portal vein recanalization, and
Yes.
they would manage that according. So they can still manage it. The experienced one would do, and it also depends where is that and how much thrombosis is. While you also need at times a CT scan before you do even consider these patients for tips. The reason is simple, that you would like to have the anatomy, you would like to rule out an HCC, because these in our setup, the patient will present
Mhm.
to you. You don't know whether they have an HCC or not, whether this tumor thrombosis is a tumor, the thrombosis is tumor related or otherwise, even if you do a Doppler and there is a mass. So you need to have
Exactly.
some imaging in the form of a CT scan or an MRI. And it is at times very difficult in ACLF, because as you know, that these patients are hemodynamically unstable, managed in ICU, and they will have a high creatinine. So it's very, very challenging to say that preemptive temps works. However, this data does suggest that if you manage the portal hypertension, definitely we know that the mortality will be lower. As we know from the previous studies of including even controlling the portal hypertension with beta blockers or band ligations and everything else. However, It is basically the hepatocellular failure which will lead to death and more complications, including ACLF is per se, an event would lead to it and then would death. I'm sorry for a very long sort of comments, but that was
So,
what I felt were appropriate.
Thank you very much,
Jeet.
Dr. Saleh, for an excellent explanation and explaining things further to us. Dr. Zaigham, he is having raised hand. I'm unmuting you, sir. Kindly add your comment.
No, I just wanted to say that Dr. Altaf Alam noticed that still we are having screen sharing. So administrator should note that when the presentation is finished, then we should have the participants mode on. So if Dr. Altaf is still there, then I can also read Dr. Kashif also. So have they any comments about this, about the presentation or study?
Okay, sir. I'm unmuting Dr. Altaf Alam. I will take his comment, sir. Ji, sir. Dr. Altaf, sir.
Thank you very much. Excellent presentation, Asim.
thank you, sir.
Raises a very good point, not only for the optimum management of acute variceal bleeding, but also those patients who have ACLF. Dr. Saleh has really highlighted some very, very important points, differentiating rescue from preemptive tips. Based on clinical endoscopic criteria, it may be worth adding HVPG criteria to that as well, to identify objectively those patients who are unlikely to do well and rebleed later on. Dr. Saleh has also highlighted the importance of the grade of ACLF as, you know, based on APASL and EASL grading. The higher the grade, the more the mortality. And now people are moving towards early transplant somewhere between 1 week to 10 days from the onset of ACLF to decide, because this is the optimum time. If you don't intervene at that stage and your patient goes into 3, he's gone. 28-day mortality is very, very high. If you let the patient slip from 2 to 3, again, you lose this window of opportunity. So Dr. Saleh has very clearly highlighted the importance of identifying this window at an early stage in the management of ACLF, which will, save patient lives rather than letting them progress into a stage where you would not even consider them for transplant. Maybe you triage them to palliative care if they progress in time. So, but this study really highlights one important point without going into the nitty-gritty of the grading of ACLF and HVPG measurement, that there is a role of management of portal hypertension or preemptive tips in early acute variceal bleeding, whatever the class of patient. So this study really gives you an impetus to look into it further in other categories of patients as well. And now Bovino 6 has already recognized this, and they have made, although weak recommendations, but they make recommendation about going towards preemptive tips rather than rescue tips, because then it may be too late and the patient may not survive. So a very good study, really learnt a lot from it, and very good discussion so far. Thank you very much.
Thank you, sir. Altaf Alam. Dr. Saleh, you are unmuted, sir. You want to add something else further?
Sorry, in the long comment, I just forgot one thing, that when these patients, and Dr. Altaf did mention those, that when these patients are in the ACLF 3 and they are in the ICU setup, one needs to apply the SOFA scoring system, which predicts mortality. The just a week ago or so, we had a patient with a mortality of a 95% or so, is based on that. So, so the question would arise that the timing of a liver transplantation. So, while you are managing one aspect of a bleeding or rebleeding, do not forget to lose that opportunity. Once you have rescued even if that patient should be actively followed and referred to a liver transplant center. The reason is simple, that we need to properly manage and give him or her a liver, which is the definitive treatment. So that was just one more thing. Sorry.
Thank you, sir. Dr. Kashif Malik is here, sir. I'm unmuting you, sir. If you have some comment, kindly add. Ji, sir. Hello, sir. We can't hear Dr. Kashif Malik. I'm going. जी सर डॉक्टर ज़ैग़म जी सर.
हाँ नहीं, जब तक मैंने कहा काशिफ नहीं आते, तो now in SOFA scoring they are including COVID also. Is this a patient of COVID, or are you including this when you are calculating SOFA in your institute?
Currently, we are not, at least not doing this. I'm not sure for others. So
while we do COVID testing on admission of each and every patient to,
because if you see MedCalc calculations, then at the end you will find that they have included. So I am not sure, because we have seen so many patients. So in this COVID era, so I think that also becomes important when you are doing liver transplant.
Sorry, I was waiting for someone to unmute me.
Yes, sir, you are unmuted, sir.
Yeah. So the COVID is an important factor these days, and one should never forget. We routinely would do the COVID testing on admission, and luckily so far, not in this condition, but we had five transplants postponed in the month of June due to asymptomatic COVID infections and very subtle HRCT changes on just the screening. When we have now a protocol of bringing them to hospital, doing these tests. If they are negative, we admit them, then we observe them for more 48 hours, and then would do another testing, and then would go for a liver transplantation. So we are considering in the liver transplant like that. Luckily, so far, not in otherwise patients we have seen COVID. And one should never forget this these days. Whenever you have now respiratory symptoms or patients who present with derangement of LFTs and so many other things, as we learn every day, and a new syndrome of COVID. One should never forget that. I absolutely agree with Professor Zaigham.
Thank you, sir, for your valuable comment. We are having Dr. Atif Majeed. I am unmuting you, sir, and I'm thankful to you. You supervise this activity from DAO and help out Dr. Ahsan. I'm unmuting you, sir.
Can you hear me?
Yeah,
can you hear me? Okay, thank
yes,
you,
sir,
Yousuf. Thank you, Yousuf, and thank you, Ahsan, for the presentation. Looking at the presentation, I think the gastroenterologist will soon learn how to do tips, because it seems as if the tips doing preemptive in patients who got ACLF really benefited them. But again, the numbers were small. I just wanted a comment that in this study, they did not actually comment on the endoscopy intervention, whether it actually was able to get a good control of the bleeding or not, or what were the findings in patients who got preemptive tips done as compared to those who not had preemptive tips done. Maybe endoscopy, substratification, and then data analysis could help us better identify those patients. For example, someone who's got large variceal with active spurting as compared to someone who's got a fundal varus that is actively bleeding. that might help us to decide which patients to actually go on for preemptive tips, because tips is not done in all centers. You have to have a very good interventional radiology center.
Yes, so these are the
So these are
few
my comments.
these are the few drawbacks of the study, but this study has opened a window for future studies to investigate the role of preemptive tips in patients with ACLF. Though it is a bit risky because we can lose our time for the transplantation, as these patients may quickly move from ACLF grade 1A or 1B to ACLF grade 2 or grade 3, as the Dr. Saleh explained. But still, in this group, we have very little to do something to prevent these patients' lives. So we have what I can say that and open a window for future studies, which may further investigate or the role of the impact of preemptive tips on these patients.
May I add something? Hello, may I say
Ji
something?
sir. Yes sir. Yes sir.
Achha, while you are putting tips, there are many factors that may govern the outcome of the tips, like diameter of the tips,
Yes, sir.
whether you are putting in the right branch or left branch of the portal vein, whether this is covered or uncovered, and whether this is covered with PTFE or not. So did they consider all these factors also while they were doing analysis? What type of stand diameter and position of the stand?
And also, they
So,
didn't mention the type of tips they performed or the type of stand they they place, because it is basically a data analysis study. So
okay.
they were just able to retrieve from data that these number of patients receive the preemptive tips. So they didn't mention actually the type of tips or the type of
Because
stand.
when you are doing procedure, then you do not what diameter of the stand was used and what was the exact position of the stand. So they did not consider that.
So it is one of the drawback of this study.
Oh,
Dr. Saleh, your input, sir.
Uh, just like Professor Zaigham Abbas mentioned, I would also bring another point in that whenever we place a tips, we sort of calculate the risk of post-tips decompensation as well,
Yes.
which we usually I would say, we use Emery model. And that would say that if it's an emergency tips, which is in this case one, yes, when you have an ACLF, your bilirubin will usually high. So the bilirubin will be more than 3. So this is another one. And then, of course, were there any, if the patient is in NCAF, active NCAF, that's another one. And the third one will be that what was the transaminase level, more than 100 or less than that. So these are those things which these are the parameters which we see while we put a TIPS shunt. So I don't know that whether we need to revisit in this particular uh, setting, whether that the Emery model is applicable to this or not. Because it seems that putting a TIPS, even in ACLF, which would place these patients at a high risk of post-TIPS decompensation, going into encephalopathy and requiring the diameter reduction or even blocking a TIPS, requiring that and blocking the TIPS, rather than going that way. These patients, majority of them improved, and the mortality was less. So just like Emery model may not all the time apply, which I myself believe that it may not apply in the setup of Budd-Chiari syndrome as well, probably. So I don't know whether one needs to. I'm sure future studies will address this as well. But routinely we would use, so whenever we put a steps, would use Emery model. Otherwise, we go for liver transplantation.
Ji, thank you, sir, for your excellent and valuable comments. I can't see any further raise hand or any questions. So Dr. Zaigham, if you have any input, kindly. Otherwise, we have to wind up the meeting then.
No, thank you very much. I think next week, Journal Club will be having presentation from Glasgow, and Dr. Johnson would be presenting paper. And let me just check for a minute. So we'll circulate on Monday the paper and the details. So next week we'll be having Journal Club again by Dr. Johnson, who is the registrar in gastroenterology at Royal Infirmary, Glasgow. Okay, thank you very much.
Thank you, sir. I'm very much thankful to all the participants. I'm thankful to Syed Ahsan Ali Darbari, who presented such an excellent paper. I'm thankful to all my senior faculties, especially Dr. Salih, Dr. Zaigham, Dr. Altaf Alam, Dr. Atif Majeed, who had their input. And we'll see you on next Saturday, inshallah. Thank you all. Allah Hafiz.
Thank you.
Thank you.